All right, welcome to today's Explainer. Today, we're diving straight into the medical data behind one of the most critical, yet surprisingly misunderstood conditions in women's health. We're talking about pelvic inflammatory disease, or PID. We're going to unpack exactly what this condition is, how it behaves in the body, and why catching it early isn't just important, it's absolutely vital. So let's jump right in. Picture this. A young woman walks into your clinic. She's complaining of lower abdominal pain, a slight fever, some abnormal vaginal discharge, and she mentions experiencing pain during intercourse. Now, at first glance, you might be thinking, okay, straightforward localized infection, right? But there is a massive, silent threat lurking here, because what turns this seemingly simple presentation into a silent cause of lifelong infertility, chronic pain, or even life-threatening complications? Well, that is exactly what we're going to figure out today. To map all this out, here's our agenda. We'll quickly cover 1. The silent pelvic threat. 2. Anatomy of ascending infection. 3. Recognizing clinical features. 4. Complications and long-term risks. 5. Diagnosis and combination therapy. And finally, 6. Prevention and key takeaways. Okay, Section 1, the silent pelvic threat. So, PID isn't just a generic catch-all term. It refers specifically to the infection and inflammation of the upper female genital tract, and it's a condition that can encompass a whole host of areas. We're talking about the endometrium, which gives you endometritis, the fallopian tubes causing salpingitis, the ovaries, which can potentially form a tubo-ovarian abscess, and even the pelvic peritoneum, resulting in pelvic peritonitis. Basically, you're looking at a broad upper tract attack. Moving on to Section 2, Anatomy of Ascending Infection. Let's trace the actual anatomical journey of this disease. Normally, cervical mucus acts as a highly effective protective barrier that keeps things out. But in PID, these organisms somehow manage to bypass that defense. They start down in the lower genital tract at the cervix, they ascend right up into the uterus, and finally, they invade those delicate fallopian tubes. It's a classic ascending infection. And honestly, understanding this pathway is the key to understanding all the damage it leaves behind. What's really fascinating here is the stark contrast between the two major sexually transmitted organisms driving this whole ascending infection. On one hand, we've got chlamydia trachomatis. This is actually the most common cause of PID, but it's tricky because it frequently produces super subtle symptoms. It's a dangerous, silent threat because the patient might have literally no idea they're even infected. On the other hand, you've got Neisseria gonorrhoeae, which tends to be way more acute and highly symptomatic. And we should also note that PID is commonly polymicrobial, meaning it often involves a whole mix of other organisms like anaerobes and enteric bacteria too. Next up, Section 3, Recognizing Clinical Features. When a patient does present, what are the common warning signs you're actually looking for? Well, lower abdominal and pelvic pain are huge indicators. You might also see a fever, prurient vaginal discharge, dyspareunia, which is pain during intercourse, and abnormal bleeding. And when you're doing a physical exam, finding adnexal tenderness and cervical tenderness, those are highly specific red flags you just can't ignore. But there is one clinical finding here that is just so classic, it absolutely demands your attention. Imagine you're performing an exam, and you induce pain during cervical movement that is so severe it makes the patient react dramatically. In medicine, this is classically known as the chandelier sign. Named because the pain is so sudden and intense, the patient practically reaches for the ceiling. It's a striking medical reality and a major, major diagnostic clue. All right, let's look at Section 4, Complications and Long-Term Risks. If we literally trace the timeline of this damage, it reveals a pretty stark progression. In the initial days, you get acute inflammation as those organisms ascend. Within weeks, this leads to intense tissue edema and pus formation. This can actually create a pyosalpinx, which is literally a pus-filled fallopian tube. Not great. As months pass, this repeated inflammation causes intense scarring. And over years, that scarring leads to complete tubal obstruction. You can develop a hydrosalpinx, which is a permanently blocked, fluid-filled tube resulting entirely from that chronic damage. So here is the absolute crucial point. What does all that scarring and blockage actually mean for the patient? It leads straight to our number one most feared complication, infertility. That tubal scarring physically impairs the transport of the ovum. And the math here is pretty harsh. The risk of permanent infertility goes up significantly with every single recurrent episode of PID. But even aside from infertility, the stakes remain incredibly high. Those damaged tubes drastically increase the chance of an embryo implanting outside the uterus, leading to tubal ectopic pregnancies. Plus, all that persistent inflammation and those adhesions, they cause long-term chronic pelvic pain. The infection can also wall off and form a tubo-ovarian abscess, a really serious mass involving the ovary and fallopian tube that can rupture and become totally life-threatening. And finally, there's Fitzhugh-Curtis syndrome. This is perihepatitis, or inflammation of the liver capsule, which is classically linked to chlamydia. It causes right upper quadrant pain and leaves behind these highly distinct Violin string adhesions stretching between the liver and the abdominal wall.
Moving into Section 5, Diagnosis and Combination Therapy. Let's see how this builds our action plan.
So PID is primarily a clinical diagnosis. You're basing it on lower abdominal pain plus cervical motion or adnexal tenderness. The rule here is you treat early, even before you get the lab confirmation back. For outpatient therapy, the standard regimen includes ceftriaxone, doxycycline, and metronidazole. But you have to watch for strict red flags that mean a patient needs immediate hospitalization. Things like pregnancy, severe systemic illness, spotting a tubo-ovarian abscess, or if that outpatient therapy just flat out fails. Oh, and a quick reminder, sexual partners absolutely must be treated too to prevent reinfection.
Now, looking at that outpatient regimen, you might be wondering, why are we throwing a 3-drug combination at this right out of the gate? Why combination therapy? Well, the answer is simple. PID is almost never just one bug. It's a polymicrobial attack. Because we're dealing with multiple organisms at the exact same time, from chlamydia and gonorrhea all the way to your anaerobes, we need a broad-spectrum defense. The primary treatment principle is you have to hit it hard and hit it early, with broad-spectrum antibiotics to immediately halt the disease's progression and prevent that permanent tubal scarring.
Bringing it all together, Section 6, Prevention and Key Takeaways. The clinical equation for preserving long-term reproductive health is actually pretty straightforward. It starts with safe sexual practices and, absolutely crucially, STI screening, especially checking for chlamydia in sexually active young women. So step 1 is screening. Step 2 is aggressively treating those early infections before they ever get the chance to ascend. And step 3 is the direct payoff, a massively reduced risk of infertility and ectopic pregnancy. Ultimately, pelvic inflammatory disease is one of the most critical gynecological infections we face, entirely because its consequences last a lifetime. Which leaves us with this final thought to chew on. If a simple screening today can prevent permanent, lifelong structural damage and completely preserve a woman's fertility, how can we make early detection a non-negotiable standard in everyday women's health? It's a vital question for all of us to carry forward. Thanks for joining me for this explainer, and keep exploring the science.